Okay. Very good afternoon and welcome to our session on fibroid uterus. We are glad to have our expert doctor Sujata Sharma to talk about the topic in detail. The doctor will help us understand the topic in brief, and if there's any questions, any doubts, you can put on the comment section, and our doctor is there to help you out with that. Doctor, you have the stage.
Good afternoon, everyone. Today we are going to talk about a very common condition amongst women, that is fibroids. Almost I think every woman must have heard about this term fibroids, because from your friends, from your families, or from your neighbors, anywhere, it's because it's a very common benign condition. Benign, I mean, it's not a malignant, it's not a cancerous growth, it's a sharif wala benign tumor of the uterus, the uterus muscle of the uterus, the wall of the uterus. Okay. These are basically monoclonal tumor cells. Monoclonal, I mean, they arise from one cell by division, by due to some division, under some influence, which may be a genetic influence in a susceptible person, and the influence comes from the hormones that we normally have in our body during our during the time, as long as we have the menstruation, that is estrogen and progesterone. And under the influence of these hormones, one of the cell just decides to divide into two, and then 2 to 4, 4 to 8, and then we have this tumor, which is, that is what we call a monoclonal tumor. Monoclonal means developing from a single cell in the myometrium or the muscle of the uterus. Now, as I said, these are very common tumors, and the incidence is somehow dependent on ethnicity also, and its incidence is maximum in Black American, African American women, and what the literature says, that more than 60% of the women will have fibroids by the age of 35 years, and more than 80% of them will have fibroids by the age of 50 years. Whereas in white women, the incidence is 40% by age of 35 and 70% by age of 70. The Hispanics or the Asians, or we come somewhere in between these two extremes, and that means still in India we have a high incidence of these fibroids. So it is expected around 60% of the women will have fibroids at some stage in their life. They may be detected accidentally while you get an ultrasound done for some other purpose. They may be silent, they may remain silent, they may not cause any trouble to you throughout your life, or they can cause trouble also depending on their location. Now, when we talk about the location of the ultrasound, this thing, fibroids is very important. So when we have a uterine cavity, a cavity of the uterus and the wall of the uterus, right? The fibroid will develop within the wall of the uterus. Okay, if I sit like this, the fibroid will develop within this wall of the uterus, and this is the cavity of the uterus. Now, a tumor which is more close to the tumor, to the cavity, more towards the cavity, there is a classification starting from grade 0 to grade 8, depending upon how close or far away from the cavity it is. So the tumors which are more close to the cavity, totally projecting into the cavity or partially projecting into the cavity, they are the ones which are more likely to produce symptoms. The ones which are there within the wall of the tumor, they can also produce symptoms, but not as much as the ones which are more close to the cavity. And the tumors which are more towards the outer side of the uterus, they are the least problematic tumors, and they are the ones which may not be detected unless you get an ultrasound done for some other problem, and a chance finding comes that you have a fibroids. And if such a situation is there, I assure you there is no need to panic, no need to panic. बड़े शरीफ से ये ट्यूमर्स होते हैं जो हमें कुछ नहीं कहते. अगर हमें कुछ नहीं कहते तो हम भी उनको कुछ नहीं कहते हैं. We just keep a watchful expectancy. We keep a watch on them, periodically getting an ultrasound done to see whether they are increasing in size, or they are just static, or whether they over the period of time they can produce some symptoms or not, and accordingly we can manage these tumors very nicely. As I said, these tumors are hormone dependent. That is one thing which is very important to understand, because hormones start producing, we start producing hormones as soon as our periods start, menarche, at the menarche. And once our periods stop, the ovarian function stops, that is at the time of menopause, all the hormones are not there. So these fibroids, even if they are there, symptomatic or non-symptomatic, they will regress in size and stop troubling you. That is something very important. But how do they develop, and why do they develop? Why is not exactly known. As I said, much is dependent upon genetic susceptibility also. So if you have your sisters, your mother, or your close relatives in the family on your side, the maternal side or paternal side, then you can also become a candidate to have fibroids during your reproductive life. But those who do not have any history, they will have very little chance, less chance compared to those who have a genetic susceptibility to have, or a hereditary susceptibility to have fibroids. Ethnicity, as I said, is another very important thing. So these are basically the reasons why the fibroids develop, but what actually leads to that trigger is still a mystery. But once that trigger is there, then they gradually keep on growing. Now these are very slow growing tumors. They hardly grow at a rate of say 9% of their size, or less than 1 centimeter per year. That is the rate of growth of fibroids. So they should not cause any much problem, unless of course either the size is too big or they are causing some menstrual irregularities. So what problems can these fibroids cause? The fibroids, they can cause the most common problem with the fibroids is excessive bleeding during periods. And it is very typical that this bleeding is cyclical. The length of your cycle is not disturbed. If you're having a cycle length of 28 days or 30 days, this will remain 28 or 30 days. Only thing is, your the bleeding at the time of menstruation, that will increase, the amount of bleeding will increase, or the number of days you bleed, from 3 to 4, 4 to 5, 5 to 7 days you can bleed, and it will be excessive bleeding. And if you are not careful about this thing and you think you can manage your bleeding well, ultimately this can lead to anemia or a fall in hemoglobin levels as well. So as I said, this is one of the most common presentation, that is the excessive bleeding during periods. Now, if you are having irregular bleeding during periods, right? Irregular, I mean even in between the cycle, two cycles, you are having bleeding or spotting continuously or irregularly during a cycle. In that case, you will consult some gynecologist definitely, and ultrasound can be done, because as I said, these tumors are hormone dependent tumors, estrogen dependent tumors. Now these hormones can also cause some other problems on the uterus, resulting in irregular bleeding during the in between the cycles also. And sometimes what happens, the tumors which are inside the uterine cavity, okay, the uterus tries it feels irritated due to the presence of these fibroids within the cavity, and then it starts pushing it towards the outside, towards the cervix, towards the vagina. And if by chance the lower pole of these fibroids, they become polyps, if they are projecting outside the cervix into the vagina, we call them fibroid polyps. And in that case, these polyps, they can get infected, they can get ulcerated, and they can also cause this kind of irregular bleeding in between the periods. So in any case, if fibroids is the reason, so these can be the reasons of irregular bleeding. Otherwise, those which are inside the cavity or which are inside the muscular wall, or even outside, towards the outsider wall, if they increase the total volume of the uterus, they increase the thickness of the inner lining of the uterus, so you will have just heavy periods which are regular, cyclical in nature. Another problem can be there in women who have not had yet conceived. So infertility can be a problem with fibroids. What kind of fibroids will cause infertility? Obviously, the ones which are towards the cavity, because they will distort the cavity, or they can block the, if they're close to the openings of the tubes on the uterus, then they will block the tubes and passage of sperms towards the egg, maternal egg, and that will not let the fusion happen and let the pregnancy happen. So infertility can be there in case of submucous fibroids, or the fibroids which are more towards the cavity. And the other fibroids which are into the myometrium, they are very less likely to have any impact on the fertility of a woman. And still farther away, the one which are towards the outer side of the outer wall of the uterine cavity, they are not likely to affect the fertility of a woman. So that is another problem that can happen. And then coming to to any other problem, if the tumors are too big in size, sometimes they are, you can palpate them or you can feel them even into the abdominal cavity. If they are too big in size, they can also cause pressure symptoms on your bladder. So you'll have frequency of urine, you'll tend to pass urine more frequently, you will have retention of bladder. These big fibroids, they can cause pressure effects on the ureters and then back pressure on your kidneys, resulting in incomplete evacuation of the urine. So that again is something of concern if such a thing is happening, which can be very clearly seen on ultrasound and appreciated on ultrasound. In that case, again, you need to consult immediately, and appropriate treatment will manage this condition very nicely. So if a woman becomes with fibroids, becomes pregnant, right? What problems can it cause? Do they cause problem or do they not cause problem? Again, that will depend on the location of the fibroids. The fibroids which are more towards the cavity, as I said, because they distort the uterine cavity, they may interfere with the passage of the sperms up towards the tube and can result in infertility. That is one. But even if the woman conceives, these two big fibroids which are impinging onto the uterine cavity, they can cause abortions. Okay, and later on they can also cause early delivery, preterm delivery, that means delivery before the expected date of delivery as calculated by your LMP. They can also, if the placenta happens to be implanted onto the site under which the fibroid is, this placentation will not be a very effective placentation. So this can result in placenta separating from the uterine wall even before the delivery, abruptio placentae, that is what we call. Or it can also lead to growth restriction to the baby, newborn baby. Then during labor, again, if a normal delivery is planned, then again a tumor which is obstructing the cervical canal, which is lying over the cervical canal, that is the outlet of the uterus, will not allow a normal vaginal delivery. In that case, the surgeon will have to resort to a cesarean delivery to deliver the baby out of the uterus. But there are fibroids which are normally there in the upper portion of the uterus or within the wall or towards the outer cavity. They may not cause any problem throughout pregnancy, and pregnancy just goes uneventful. But again, during after the delivery of the the baby, the third stage, that is third stage, is when the placenta is being delivered. So we can have problems at that time. If the placenta happens to be an adherent, there can be a little difficulty towards the delivery of the placenta, and some bleeding can happen, but that can be easily managed once we know the fibroids are there. So everyone is fully prepared to tackle this kind of a situation, so nothing to worry about that. Anyhow, as I said, during pregnancy, if you have fibroids which are there on the within the wall of the uterus or towards the outer side, they will not cause much problem during pregnancy. But the ones which are towards the cavity, they are the ones which are likely to cause problem. And not that in 100% of the patients they will cause problem. Sometimes the pregnancies go totally uneventful and patients do deliver normally vaginally. Now, what treatment do we give, or what treatment should we give to the patients who are having fibroids? If the fibroid is a chance finding, okay, and it's not a very big size uterus which is pressing upon the adjacent structures, patient is not having any urinary problem, you are not having any problem while defecating, then we can just go for watchful waiting. We can just keep them under observation. We can get ultrasound done every 6 months or every year, because as I said, they are very slow growing, grow hardly by 1 centimeter per year, 1 to 2 centimeters per year. So if they are not causing us much problem, we will also not trouble them by fiddling with these benign tumors. And then in that case, we can simply wait and watch. So more if you are towards the perimenopausal age group in your 40s, by this watchful expectancy, if you go by that time into menopause, these fibroids will automatically recede in size, they will shrink in size, because there are no hormones left now to support these fibroids. That is one option. But if they are causing problem will be menstrual problem. You are having heavy menstrual bleeding, so for that some management has to be given, because we do not want our patients to become anemic because of a heavy menstrual bleeding. So a variety of medical options are available. Some to begin with, we can start with some NSAIDs. NSAIDs are like aceclofenac, diclofenac, so these kind of, especially if the pain is there. Now, pain in a fibroid will be there. We call it dysmenorrhea. Dysmenorrhea is during menstruation. If a woman has pain and is having fibroids, again it will be a submucous fibroid or a fibroid within the wall of the uterus, which is more likely to cause dysmenorrhea. And dysmenorrhea will be only towards during the periods. But if the tumors are very large in size, the woman may just have a feeling of heaviness in her lower abdomen, and then all those symptoms, back pressures on the kidneys and everything, urinary problems and defecation problems, all those problems can be there. Now, if bleeding is only there, or pain is the main problem to you, then you can start, or you can take this during periods. So the moment you start feeling this discomfort, don't wait for the peak of the pain to take place, and then you take some NSAID or analgesic like diclofenac, Voveron, or aceclofenac. A lot of preparations are available in the market, but of course that has to be prescribed by the gynecologist you are visiting. So you can take those tablets to take care of the pain. So as I said, the moment you start feeling discomfort, start with the treatment. You can take two tablets a day, 3 tablets a day for 3 days or 4 days or 5 days, as long as you have pain. But if you do have pains only for the first 2 days of the periods, and then you don't have any pain, so take it only for 2 days, no need to take it for further. But these NSAIDs, they will not be effective against a heavy menstrual bleed. So if you are having heavy menstrual bleed as well as pain, then we can change the medicine. There is another option, tranexamic acid is available. Again, we can give you tranexamic acid. This also will effectively, significantly reduce the amount of blood bleeding. Now, this kind of a treatment is meant for a person who just does not want to get operated, or who is near menopause, in a perimenopausal age group, and we just want some time to pass so that the woman gets into her menopause, and then there will be no problem thereafter. So to pass time, that is this kind of a treatment we can give. Or a young patient who is having waiting for pregnancy till the time she becomes pregnant, or not become pregnant. If she becomes pregnant again, till that time we can give this expectant treatment. So tranexamic acid, as I said, will significantly reduce the amount of bleeding, and if the pain is there, then we can give a combination of tranexamic acid and mefenamic acid, and they will take care of both the pain, dysmenorrhea, as well as the amount of heavy bleeding. Then basically the treatment of fibroids can be a medical treatment or a surgical treatment. Okay, medical treatment is a temporary measure, purely a temporary measure, where we want to gain some time before a final definitive surgical management can be there. So a lot of options are there. I said but these two have I have said. Then there are certain medications which will, when taken, they will reduce the amount of fibroids significantly. And when the amount of, or the volume of the fibroids reduces significantly, your symptoms will also reduce significantly. Like we have some GnRH agonists which can be given monthly injections or 3 monthly injections, and they will cause around 38%, 35 to 38% reduction in the size of the uterus. Sorry, in the size of the fibroids, and accordingly you will have a significant relief in bleeding, heavy bleeding. In fact, the bleeding may just get down to spotting during the duration of the treatment. But then all these medications, they have their side effects and are not given beyond 6 months. Okay. Now, GnRH agonists, which I am talking about, these are injectable, monthly injectable. The main side effect is like it induces a menopause type of a state, where you can have bone loss, or you can have some vasomotor symptoms, mood instability, depression, or irritation, or sweating, that kind of not in all the patients, but in some of the patients these problems can be there. And and if some patient is showing this kind of side effects, there's no need to stop the therapy, but there are certain drugs which are available, which we add as an add back therapy, because we can give calcium when the patient, when you are on these agonist drugs, along with, as long as you keep on taking medicine to prevent any bone loss. And if vasomotor symptoms are troubling you, then we can add a small amount of hormones along with these, and you can have a good amount of recovery from your symptoms. And the symptoms patient and the symptoms, as per literature, from 6 to 12 months after the stoppage of the therapy, you will remain symptomless. But one thing is there: any type of medical therapy for fibroids is only a temporary measure. The moment you stop this medical treatment, the fibroids will regrow to their original size. This treatment or any other medical treatment cannot be given for more than 6 months. So after the end of 6 months, another 6 months, when you stop, the fibroids will have regrown into to their original size. However, the symptom release can persist for further 6 months. So basically, this medical treatment is a time gap arrangement. If you do not want to get operated very soon, you want to gain time for some reasons before surgery, or there may be people who are medically not yet fit for surgery. So it's a time gap arrangement, not a permanent arrangement. Then there another options are there. Mifepristone is another drug. Then the Urlipristil is another drug which is very commonly being used. And then there is a device which is more like a copper intrauterine device. Mirena, we call it the trade name. This also is one drug It releases drug inside your uterus, which helps in controlling bleeding. Now remember, while mifepristone, ulipristal, and GnRH agonists, they reduce the size of the shrink the size of the myoma by varying degrees, varying from 35 degree to 48 degree with different combination of drugs. The Mirena LNGIUS, the hormone releasing copper device, this mainly takes care of the bleeding part. It will not cause shrinkage of your fibroid. And of course, if the fibroid is within the cavity of the uterus and is distorting the cavity of the uterus, in the patient, you are unfit for insertion of Mirena. It will not just go inside because the cavity is being blocked by the submucous fibroid. Okay. So these are basically the medical treatments which we can try to gain time before you want to conceive, before you get into menopause, or for some other personal reasons you want to delay this thing. These managements can be there. The permanent management of fibroids is surgical treatment. Now again, I will repeat, if your fibroids are a chance finding, they are not causing any problem to you, there is no need for any medical or surgical treatment. This medical or surgical treatment is meant mainly for the women who are having menstrual problems, or some pressure effects because of the large size of the fibroids. So surgical management is, that will much of it will depend upon the whether fertility is required or fertility is not required, what is your age, the desire of the patient to retain her menstrual function, that is to retain the uterus or not, and then all this will depend. In a younger woman, supposing fibroids are causing problem in fertility, a problem of fibroid which is towards the cavity of the uterus is causing problem in fertility, in that case we can remove only the myoma, the fibroid, we call them myomas. And the surgery which is there, which is done for these myomas, is myomectomy. Myomectomy means we only remove the myomas. Now it's not that a single myoma is there and we can remove only one myoma. Even if you have 10 myomas or 10 fibroids in your uterus, they can be, all of them can be removed during one surgical procedure only. Okay, but much will depend upon the site of the tumor and the choice of the patient. This can be done, this myomectomy surgery can be done by a laparotomy. That means by an open surgery, open abdominal surgery, myomectomy can be done. This can be also done through a laparoscope, and if we do it through laparoscope, then it is basically the myomas which are towards the cavity, towards the outer wall of the uterus or into the myometrium, but close to the outer wall of the uterus. So these are the kind of myomas which can be removed laparoscopically, very carefully, very successfully. These can be removed. And the myomas which are there towards the cavity of the uterus, they can be removed hysteroscopically. So endoscopic surgery is very much common, very much prevalent, very much available at our center and at other Apollo centers. And through hysteroscope, the myomas which are projecting into the cavity, partially or wholly, they can be removed through a hysteroscope through the uterine cavity only. So these are basically the surgical procedures. It's very important that while the surgery should be done by a trained gynecologist only, because it's very important that we take care of the lining of the uterus while removing these myomas, either from the cavity of the uterus or while removing from the muscle of the uterus. So a careful surgery has to be done by a trained gynec endoscopist. Okay. Then there are certain options available which are non-surgical options, and this is available at some selected centers, not at all the centers. Uterine artery embolization. So what we do in uterine artery embolization, just when if you know about this cardiac stenting, okay, so we insert a tube through your one of the vessels in the leg and into the uterine, the arteries which are supplying the myomas, the fibroids. So we can inject small beads, microscopic beads, to block those vessels which are supplying blood to these myomas. So once the blood supply is blocked, these myomas will shrink and will disappear or will shed off into the uterine cavity and then can be removed later on. Now again, with this uterine artery embolization, as many myomas as is possible as are there can be they all of them can be taken care of, so patient can be comfortably go home by evening, because it's a very very not a minor procedure, but a procedure which doesn't require a lot of cutting and everything. But there's a big but. This uterine artery embolization is not meant for women who are yet to complete their family, because there are certain issues which have been raised regarding fertility issues, childbearing, once this uterine artery embolization has been done. So women who have completed their families and are not willing for a big surgical procedure like a myomectomy or removal of the uterus as a whole, which we usually suggest in a woman who is perimenopausal to nearing her menopause. So uterine artery embolization is meant for a woman who is already completed, doesn't desire further fertility, for those women. One such more procedure is available, and that is MRI guided focused ultrasound. HIFU, you may have heard of this name. HIFU is again through an ultrasound, and this is a machine which is a combination of MRI and and ultrasound energy is then focused onto the fibroid, and it's strong enough to dissolve that fibroid. Okay, so this again is a procedure which is a painless procedure. You just have to lie on the MRI table and the procedure is done digitally, automatically, digitally. And of course, the sitting is a little longer, but once the procedure is over, you can easily go home, and then you can wait for the this lysis or resorption of the myomas, or shrinkage of the myomas over the time, and a relief of your symptoms. Now this MRI guided focused ultrasound HIFU is again not meant for women who are desirous of having of childbearing, who have not had their children as of now. So for all those women, HIFU can be done. HIFU can be done. So these are basically the treatment modalities for this thing, managing patients of fibroids. And again, if the woman is nearing menopause in her late 40s and has fibroids which are big enough to cause pressure effects, or which are causing heavy menstrual bleeding, in those women we suggest that we do hysterectomy. Hysterectomy means a removal of the uterus rather than doing a myomectomy, because there's no fun of now retaining that uterus, because the woman or you are almost going into the menopause. So in that case, it's we would rather recommend doing a hysterectomy. That means removal of the uterus along with the myomas, of course, will be removed along with the uterus. But of course, that choice is for that is the choice of the patient. Much will depend upon the choice based on the options that I have just elaborated. But the suggestion of any gynecologist for a woman who is nearing menopause in her late 40s or early 50s and still not gone into menopause because of the presence of the fibroids, the choice would be hysterectomy. Now, there are certain reports or certain things in the you can find on Google or some media reports that myomas can become malignant also. Malignant means a sarcoma. Sarcoma is a malignant myoma, malignant form of this fibroid. But let me assure you, as far as literature is concerned, the reports of a myomorph or a fibroid turning into a malignant fibroid are just not there, because the genetics is different, their origin is different. But because they arise from the smooth muscle of the of this thing, the uterus, so sometimes people just interpret that earlier these were benign fibroids and now they have become leiomyosarcomas. Normally, fibroids extremely rare would be if a fibroid turns into a leiomyosarcoma. But as of now, in the literature, we hardly have any reports where a benign fibroid has converted into a malignant fibroid. A malignant fibroid is more likely to happen in a later age group, after the more likely to happen in a woman who is post menopause, after her menopause. And if after the menopause there is a development of a fibroid like structure and it's rapidly growing in size, it has started causing pain in the abdomen, fibroids will not have that kind of a pain. So that will be that, then the probability of a leiosarcoma is there. But if you're misguided by anyone that this benign fibroid which was found accidentally during an ultrasound and is not causing any trouble to you, will not turn into a malignant growth, and hence there will not be any need to go into surgery. Believe me, I always tell my patients when they come panicky with the fibroid report on ultrasound and they tell me, ma'am, we have a fibroid. So the first thing I ask them, क्या कह रहे हैं आपको? Is it troubling you? No ma'am, we just found it out on ultrasound. तो मैंने कहा वो शरीफ सा पड़ा हुआ है, आपको कुछ नहीं कह रहा, तो हम भी उसको क्यों कुछ कहें? So that is the basic funda of management of a tumor which is just a chance finding. But of course, if it is a symptomatic tumor, you need to consult your doctor, and your doctor can, depending upon your choice, your age, your fertility potential, and all the factors taking into account, different treatment options can be offered, and you can decide which type of treatment option you want to go in for. So there's nothing scary about fibroids. These are very common. As I said, 60% of the women by the age of 40 years will have fibroids, small, big, whatever it may be, lying silently there in the uterus, may not be ever detected. And if they are detected, then of course, if they are causing trouble, then of course we need to take care of that. Thank you. Any questions? I can take that. There is a question, but any preventive measure, if you have them and get operated, I heard it still can come back. Okay, right. See, fibroids, they grow within the wall of the uterus. As I said, the myometrium, the muscle of the uterus. Sometimes they are such small microscopic things, right? You cannot detect them on ultrasound or with naked eye while operating. So over the time, once you have had those ones which are visible or which are causing symptoms removed surgically, and over the time, say after 5 years or 6 years, you get another ultrasound done or you become symptomatic again, you find there is another new myoma. Basically, this is a myoma which was microscopic earlier, and over the time, slowly growing, it has now grown in size and has become visible. Or actually a new myoma can grow. That probability can never be ruled out. There was one saying at one time that a uterus which does not produce children produces myomas. So having less children is also a problem that makes you susceptible to formation of myomas if you are genetically susceptible to have that kind of a growth in your tumor. Preventive measures, there are no preventive measures. If there is no means by which you can prevent the growth of a myoma, if they have to grow, they will grow. Only thing is, once they grow and become symptomatic, then you can then you should consult your gynecologist, and accordingly these can be managed. Any other question? So thank you. If there are no further questions, thank you so much for listening.